I'm a professor at Unicamp. And my group studied cisplatin and head and neck cancer, okay? And this is a study with the same patients, with either presented for us, about cellular oxidative stress. This study is about how the oxidative stress do the result about these patients. Well, in this study, I evaluable nephrotoxicity and ototoxicity, and the toxicities are caused principally by oxidative stress in addition to bind the genomic DNA. Cisplatin binds to the mitochondrial DNA, reducing the production of ATP and the activity of ATPase, change the intracellular calcium content, and reduce the cellular respiration rate, which results in the production of oxidative species and lipoperoxidation of cells. Here, can you see the cisplatin in the cell forming the complex glutathione cisplatin, then reduce the level of glutathione. Glutathione is an antioxidant molecule. Then there are increased species, reactive species, then decrease antioxidant systems, and you have oxidation of lipids, proteins, DNA, and RNA. These are the first study of my group that published in BCPT in this year about effects of a high-dose cisplatin chemotherapy and conventional radiotherapy on urinary oxidative and intracellular stress biomarkers in patients with head and neck cancer. And in conclusion of this study, shows that after high-dose cisplatin chemotherapy, there is an increase in now the studied oxidative and intracellular stress biomarkers. Here I studied T-bars, and here I studied isoprostane. On the other hand, in the appears that the radiation therapy did not influence the oxidative and intracellular stress in urinary sample. In this study, what question? Cisplatin use is restricted because the toxicities that is caused principally by oxidative stress. Previous studies on literature evaluate cellular oxidative stress only on animal models. Then my group studied first in urinary, and you know about the blood or urinary stress. Then now I will study cellular oxidative. The objective at the end of the study is evaluate cellular oxidative stress on patients with head and neck cancer in treatment concomitant with radiotherapy and cisplatin. Well, this was observational and prospective study in the same hospital in this year and continue outpatients with head and neck squamous cell with receive high doses of chemotherapy and radiation. This is approved of ethics committee. This is the complex of my hospital. Then, to evaluate the cellular oxidative stress, I did mitosox red, GCF, and Plex red before and after 5 days and 20 days of first chemotherapy cycle, where collect blood and separate lymphocytes of patients to realize these tests. The mitosox red test is a marker of superoxide mitochondrial orange, and it is determined by flow cytometry. GCF shows cell damage marker and the flow cytometer too, and Amplex red, it's a mark of peroxide, oxygen peroxide, and was determined by fluorometer. This is an example of cytometry and the lymphocyte and the fluorescence of the cells. Here is a monocyte. And this is an example of complex red things. Well, the analysis with blood before the treatment, metasox red, DCF, and plex red, treatment first cycle of cisplatin with high dose, and analysis blood after 5 and 20 days of treatment. The same things, male, underweight, the age 54, the primary tumor site 90% pharynx, the stage 4, and KPS 8%, 90%. Smoker category, heavy smokers, and now it's moderate drinkers, heavy drinkers, and very hard drinkers. The results show that the same in the paper, but by mitosox red and the superoxide production in the mitochondria, you know before and after 5 days and after 20 days. And you have a high stress oxidative cellular after chemotherapy, but after 20 days it's normal. The same thing is DCF that have cellular things that before and after 5 days and after 10 days. And the same to super of oxide peroxide, hydrogen peroxide, sorry, before, after 5 days and after 20 days. This conclusion, this is a small study yet, okay? The tests show a difference between the realized before and after first chemotherapy cycle. And then it's a big number of patients inclusion to do this, okay? And this is my grant. And this is my group of Unicamp. And this is my students of PhD, okay? And the other work.
We take that. Shall we take that continuously, or?
Oh.
Maybe we can take a discussion on this first.
Okay.
And then
Okay.
we take the other.
Okay.
Do you have some questions?
I think maybe the same thing. You mentioned now that there is cellular stress that happened to these patients after the first cycle. Did you have any connection between this
Yeah.
and
Yeah.
what happened in that?
I did this.
Okay.
And there's studies in the intermediate. Then I do this in the first, second, third cycle. Before the cycle 5 and 20 days, I have this result. It's the same. And this is a big study for me because I study the effect of N-acetylcysteine to reduce nephrotoxicity in these patients. Then I have a placebo group. This is placebo group. And I have an N-acetylcysteine group. And I compare oxidative stress, cellular oxidative stress, and blood plasma oxidative stress. I compare autotoxicity, nephrotoxicity, and reduction of the tumor. And today I have 20 patients, 10 with placebo, 10 with N-acetylcysteine, and the results show this is placebo. But then N-acetylcysteine don't have a change in the stress oxidative. It's expected, but and about the reduction of tumor. Then nephrotoxicity, it's good for N-acetylcysteine. My patients with N-acetylcysteine don't have nephrotoxicity, and the placebo have. And the tumor reduced is similar. And can be used in N-acetylcysteine how to prevent autotoxicity and nephrotoxicity in the future. This is a small study yet, phase 1, phase 2 about this. And this is only the placebo cellular oxidative stress. And I have the N-acetylcysteine cellular.
Thank you. More questions? Actually, It's a nice talk. Actually nice piece of work you have done in Brazil. So, and you want to present the other paper at once, because she had 2 papers to present. The other one, I will put that on the program later, but okay, we can take that now.
Okay. And this, the other work, né? And the name is Marilia in your program, but she couldn't go, and I will present for her. Her is my PhD student too, and this work is toxicities and treatment response related to cisplatin chemotherapy and radiotherapy, treatment in patients with advanced head and neck cancer, influence of different cisplatin doses. The introduction is the same of the other, then I didn't repeat this, okay? The alcohol, cisplatin, the main of toxicities, nephrotoxicity and ototoxicity. This is the pharmacokinetics. And the question of this study is, the adjustment of dosing of the cancer chemotherapy seems to be a major reason for treatment failure. The evaluation of a cisplatin dose, 100 or 80, and its influence of toxicities in treatment effectiveness has not been demonstrated in the literature. This is a protocol, but why 108? Okay. Then the objective of this study was determine the impact of cisplatin doses on toxicities and clinical response in advanced head and neck cancer patients in treatment with cisplatin chemotherapy and radiotherapy. This is an observational and prospective study in the same hospital. From 2 years, old patients with head and neck cancer who receive chemoradiation, 80 or 100 per cycle, and complete 3 cycles. Study approved by ethical committee. This is the hospital. And I have here 2 groups. One group 1, lower doses, 240 to 260 milligram, and the group 2, higher doses, 208 to 300, and this is accumulated cisplatin dose in 3 cycles. Okay. What comes nephrotoxicity, ototoxicity, and treatment response. Nephrotoxicity, I saw this by serum creatinine, by Kirchhoff-Gaut formula, and ototoxicity, audiometry, and the nephrotoxicity, ototoxicity was classified by common terminology criteria for adverse events, version 4. And the treatment response was due by computed tomography scan. Then I analyzed before the treatment, audiometry, creatinine clearance, and tomography. During the treatment, 80 or 100 milligram per circle, and analysis after the end of the treatment, audiometry, creatinine clearance, and tomography. Then, this is the same of the others. Oh, I don't know what. Back here. The prevalence of male, the age similar, 53, the mean. The BMI, the same, and white, the prevalence in my population. Similar pharynx is the more prevalent, stage 4-2. Here I showed the nephrotoxicity have a decrease of creatinine clearance after the treatment, but don't have a difference between these groups. But if you're classified by severity in grades 0, 1, or 2, you can see that the group 1 or lower dose have more grades of toxicity than the group 2, that higher dose. It's very strange. Very strange for me. Yeah? More things strange is coming. Ototoxicity. In grades 0, 1, 2, 3, the similar. The lower dose had more ototoxicity than the higher doses of cisplatin.
Wait.
Yeah?
Come on.
And clinical response. Complete response or partial response is stable disease. The complete response is higher in group 1 than the group 2. The lower dose have better result in clinical response than the higher dose. Yeah. Yeah. Come on. This is valuable by statistical. Don't have statistical significance between the groups, okay? Because the group is small yet, but I think it's important. The result. Then, the cisplatin dose had no significant impact on studied outcomes. However, a prevalence of complete response and toxicity was observed in group 1, the lower dose. Because of the small cohort size, large representative studies are needed to obtain more consistent results. This is my agreement and my group. Thank you.